Okay, thank you.
Yes,
I am Dr. Agodirin.
Can we start?
I'm a general surgeon with the University of Ilorin Teaching Hospital, and I'm also a university lecturer with the University of Ilorin. That's in Kwara State, Nigeria. I am also a master's in clinical research student with the Texila American University. I thank the Texila American University for giving me this opportunity of presenting this paper. Now, the title of this paper is Hematoma Localization under Ultrasound-Guidance for Excision of Impalpable Breast Lesions to make breast screening effective in low-resource centers. I am the lead presenter, and I'm the lead researcher in that research. Now, breast cancer is a major problem worldwide, and in Nigeria, most of our patients die from the disease compared to developed centers. This is what also obtains in other developing centers also. And the results we get now correlates to what used to be gotten in the developed centers about 40, 50 years ago. That our own survival rate is about 80%. I mean death rate is about 80% compared to the developing centers where that death rate is about 5 to 10%. And the main thing that has actually improved the survival of breast cancer in developed centers is because they are able to do screening and they are able to pick their lesions when it is not yet palpable, when it is still not seen by the patient, not seen by even the clinicians, when it is still in the sojourn period, that is the journey period. It does not manifested the clinical features. And to be able to do that, one needs to be able to do mammography, which is a form of X-ray of the breast, and to do ultrasound screening, which is a form of imaging technique also of the breast, to see whether there are any lesions that one could pick and then attend to that lesion. This is done in developed centers. But in developing centers, after the screening, it is difficult to get the lesions because we don't have the facilities to actually go after the lesions that we see. And the lesions may be localized using ultrasound and mammography, but in developing centers, we don't have these facilities. And in centers where they have it, the bureaucracy is so much that it's difficult to have a consistent yield from the result. So and the problem is if one is not able to detect the lesion, remove a lesion that is detected, then the screening becomes counterproductive because the patient that has a lesion that you cannot remove will have the depression, psychological mobility of having something in her breast which you cannot even attend to. So it is not advised that we should perform screening when we cannot remove the lesion. And so that is why we try to look for ways to detect and remove small lesions. Now, if you cannot remove the lesions, what we have to do is we have to wait for it to become bigger, at which time it has progressed, the treatment becomes very difficult, and then the survival rate also reduces. And the cost of treatment also becomes very high. And also, by the time the lesion is so big, the treatment that we can offer the patient becomes to remove the breast, that is mastectomy. And many patients don't usually want this. So we needed to find a way to remove the lesion before it becomes big enough. Now, the main objective based on this was to look for a way that we could remove the lesions that we see after screening the patient. And we also were looking for a way that would be easy and cheap to carry out, something that we can sustain in developing centers. And so we looked at the various available methods for removing this kind of impalpable lesions, small lesions in the breast. And we found that ultrasound-guided biopsy, which can be done in developed centers, whereby the patient goes to the radiology department, does the ultrasound, and then comes to the surgeon for the operation to remove the lesion. But in doing that, the radiologist has to be present in the theater to show us where the lump is. And that was a problem because we could not get the sonologists to change their own schedule to meet our own schedule. So we needed to find a way that we could decentralize the process, whereby the patient can come to us and then we can look for the lesion after the radiologist had already done our own part of the job. The primary thing that we wanted to do was, could we use the method of ultrasound-guided biopsy to find the lesion in the breast without having to use a machine intra-op? That was it possible for us to find a lesion blindly without having a machine to assist us? Because we know many centers in developing countries cannot have the facility for using machines in the theater. And is it possible for us to also be able to get a diagnosis after excising the lump that we find? And these were the main primary objectives of the study, to find out if we could do these two things: able to localize and excise the lesion, and then able to have a diagnosis for the patient. So in doing that, we planned this prospective study whereby the patient will first go to the sonologist after having a mammography screening that finds a lump in the breast that was not palpable. And then the surgeon also will have to go to the Department of Radiology to see where the lump is, to localize the lump by mapping, deciding which part of the breast that lump is. And then what we did was we took about 3 to 4 ml of the patient's own blood, and under the guidance of ultrasound, we injected the blood into the patient's breast where the lump was, to mark where the lump was. And then we allowed the lump, the blood, to stay for about 2 to 3 days, after which we went after the hematoma. We also planned our placement of incision at the time of the ultrasound staging. Now, at the theater, what we did was, after making incision according to the after making the incision, we had to deroof the overlying fat so that we could begin to see the lesion here, like this. We could begin to see the roof of the lesion that we're looking for. And after seeing that, we tried to excise the whole lesion. That's the hematoma that we had injected into the patient. We tried to excise the whole thing along with some rim of breast tissue. And then we sent that for histology. We did that for 5 patients over a 2-year period. It's a pilot study, so we did it for 5 patients over a 2-year period. And in the 5 patients, we were able to get all the lesions completely removed, and we were able to get a diagnosis for all the patients. We had a lot of complications because of the learning curve, which we know will improve over time. Now, we had only 5 patients because many patients were not coming for screening, and so it was difficult to get more patients into the study over the 2 years period. Also, our selection criteria was very stringent. We didn't want to just go about removing lumps that were not worth the procedure. For the patient to be in the study, the patient had to do ultrasound-guided ultrasound and mammography to detect the lesion. And then we tried to use fine needle to get the diagnosis. And then if that was not possible, then that was when the patient was actually allowed to go into the study. And the patient had to be high risk for having cancer before we could allow the patient to go into the study. Now, like I said earlier on, most of the results we got were benign lesions. But we are happy that even though they were benign for the patient, they have shown us that it is possible for us to actually detect and pick lumps that are tiny in the breast of our patients. And that will help us in improving their outcome. Although we know that we still need to do more to improve our selection criteria. Now, the weaknesses of the study was that it's ultrasound-based study which means that the lesion must be visible under ultrasound before we can progress. And then intra-op, it was a relatively blind procedure because there was no machine to help us to locate the lesion. We had to use the hematoma that we formed inside the patient's breast to remove the lump. And also we had a high rate of complication in this study. We hope that this will improve as we get more patients and as the study progresses into the more substantive study. The merit of the study is that now we are able to diagnose impalpable lesions. This is very important, and because this means that we can now diagnose our patient at stage 0, that's carcinoma in situ, at which time their survival will be very good, and we don't need to wait for the disease to progress to higher stages before we remove the lump. And then because the procedure can be done anywhere without ultrasound guidance, without technology, then we can transfer this technology to other low-income centers and that may want to also use this study. And we don't need to have a fully functional breast unit for us to do this. The method is cheap and it can be reproduced in centers in developing centers. Now, the learning point now is that now that we can make the diagnosis, remove the tiny lumps that we cannot palpate, we need to improve on our methods of detecting these lesions, and we must improve on our on our results in such that we are able to get lesions that are malignant and we're able to exclude those that are not malignant from the study. And we also need to work on the technique of the procedure so that we can reduce our complication rate. Thank you.